morning. I'm Dr. Halessa. I'm the founder and author of Nitro Medicine, and so are my team of doctors. And I have publications with Dr. Michael Hamblin from Harvard Medical School regarding using photomedicine and also phototherapy with stem cells and PRP to enhance stem cell therapy. We call this field photoregenerative medicine. But nitro medicine is actually a field that is going to address all kind of chronic disease, and we call them oxidative stress-related disease. And I think if we redefine pain condition as an oxidative stress-related disease, we can better understand the pathophysiology of those pain conditions, and also we can better understand and better treat those pain conditions. So. And so I define this field of nitro medicine as a new medical specialty that focuses on developing diagnostic and therapeutic protocols to enhance stem cell therapies and manage oxidative stress-related diseases by modulating the nitroredox-sensitive epigenetic and biochemical pathways. And when I say oxidative stress-related disease, that's mean pain, cancer, autoimmune, degenerative disease, chronic inflammation, chronic infectious disease. And if we define all this condition as an oxidative stress-related disease, I think we can better understand the pathophysiology, we can better manage those conditions and diagnose them. And of course, I'm using evidence-based medicine, which is an approach to medical practice intended to optimize decision-making by emphasizing the use of evidence from well-designed and well-conducted research. And of course, will be based on published randomized clinical or randomized controlled trials with the same results. Those protocols will know with known mechanism of action and predictable side effects, and also those protocols will be monitored by reliable, accurate, and objective diagnostic testing. So what I'm bringing to the table here is I think everybody knows about pH, which is hydrogen potential. And a pH is a measurement of the tendency of a substance to attract protons. And I think we know the importance of regulating the pH and keeping the pH within 7.35 to 7.45 in the body. And any drafting in the pH, what will happen, we will have an acute conditions which are acidosis, alkalosis, which can lead to cardiac arrest, cardiac arrhythmia, confusion, and death. So it's very important to maintain the pH at its normal level because it affects the whole enzymatic activities and electrical activities of our body. I think few of us recognize or know about redox potential. And that is a new field. It's called redox medicine. And what is redox potential versus hydrogen potential versus pH? Redox potential is the measurement of the tendency of a substance to attract electrons. And redox potential plays a critical role in almost all pathophysiology of all the chronic conditions and diseases. I think we are overlooking this important factor, which is redox potential, how to control it, and how it's controlling almost every physiological process in our body. And it regulates the cellular enzyme, electrical activity, energy flow. It regulates the cell cycle, which is the cell proliferation, differentiation, and death, cardiac rhythm, circadian rhythm, ANS balance, which is autonomic nervous system balance, brain plasticity, insulin sensitivity, vascularity, and function immune system. And if we have a normal redox sensitive metabolism, it will lead to all this chronic condition. We call them oxidative stress-related disease, such as degenerative disease, autoimmune disease, chronic inflammatory disease, cancer, and pain condition. And so this is a new concept, or we can say This is what I'm bringing to the table, and if we understand this basic science, then we can translate it into clinical word, and we can better manage chronic conditions. So the cell, when it's not dividing, what will be the redox potential of the cell when it's not dividing to Z0? It's minus 415 to minus 300 millivolts. And in order for us to drive the cells to divide and increase in size and growth, we have to increase the redox potential to minus 240 millivolts. Okay, and if we continue increasing the redox potential of the cells, it will stop dividing, and we call this quiescent stage, which is around 220. And if you continue increasing the redox potential to 200 millivolt, the cells start differentiating. And if you continue raising the redox potential to minus 170 millivolt, we will stimulate apoptotic genes and the cell will die. And if we go up to minus 150, we will induce necrosis. So this basic sign, which is in you, I don't think in medical school we learn about this. I think in the medical school, if you remember, we're talking about the G0, G1, and S, and how those kinases and protein, which is very complex. But now we narrow it down, and we boil it down, that the cell proliferation and differentiation and cell death is controlled ultimately by electrical activities. So all these cytokines, those growth factors, those PRP, those stem cells, those energy medicine, photomedicine, electromedicine, solar therapy, cryotherapy, prototherapy, they induce cell to divide and differentiate due to the change in the redox potential. That's the ultimate mechanism of all these factors or modalities, or we call the nitric redox modulation. Okay, so let's go to clinical. So we mentioned that if we go and we raise the redox potential to above 170 millivolt, we can induce apoptosis. And that concept, we can bring it up to develop a method to treat cancer. So how we treat cancer? Have you heard about cancer photodynamic therapy? In cancer photodynamic therapy, what we do, we inject into the body a photosensitizer, and that photosensitizer will accumulate in the cancers, and then we shine the light will excite the photosensitizers, generate free radicals, increase the redox potential, and induce apoptosis and kill those cancer cells. This is photodynamic therapy. Now, recently, one of my patients happened to be my dad, and he had squamous cell carcinoma, and also he has hyperpharyngeal squamous cell carcinoma. And before that, he had MI. So I rushed him to Germany hospital, and they say, well, we cannot remove the squamous cell carcinoma of his hyperpharyngeal. And if we want to treat the cancer of the skin, we're going to do a surgical excision, which will be in this shape. It will be a brutal surgery and removing the organ, because he has an old NMI, and I was working already in developing cancer photodynamic drugs in Germany with Dr. Michael Weber. So I thought about, let's do cancer photodynamic therapy. And we use photosensitizers, we use ICG, indocyanine green, which has ability to absorb infrared, but ICG nanoparticle, yes, it can accumulate in the cancer cells, but it's not as efficient as I wanted. So I'm looking for a photosensitizer that has that tendency to attract into cancer cells, especially for surface cancer cells, which is skin cancer or bucus. And I find methylene blue is being published, and it's being used to treat cancer, which is squamous cell carcinoma, but was on animal and also lab. So there's not much in human except one research I saw in Germany, a surgeon who had done some methylene photodynamic therapy with esophageal cancer. So I said, okay, I think it's better because methylene blue, there's no toxicity in it, and I'll go ahead and do it. Although I was not expecting I will be able to really kill those cancers. So we started, and I think 20 sessions, and radiating with red light, 660 nanometer, 20 sessions, I end up destroying squamous cell carcinoma. So instead of having this brutal surgery, which is one of my patient who has done this surgery to remove squamous cell carcinoma, as you see, it's very ugly and brutal, I was able to crash the squamous cell carcinoma painlessly, and my father was very excited, and I think the medical community will eventually adapt those protocols because the methylene blue has that very strong tendency to attract to any lesion that is inflammatory or that's cancer, that has high free radicals. They have a tendency to stick into cells that contain or that has high redox potential, that has high free radicals. I think inflammation or cancers are the environment where methylene blue sticks, and then they turn into dark blue as you see it here. Normal tissue, they don't stick on it because they have low redox potential, and so they lose their color and can be washed out, but they stick into those cancer cells, and those cancer cells takes them in, and we can use photodynamic therapy to induce destruction by apoptosis using the concept of redox signaling. Okay. I think because you are pain doctors, what's important is pain. And I think in pain management, we are messing a lot about the concept of central neuropathy. I think we're doing good in screening the peripheral pain generators, but we are kind of overlooking the central pain neuropathy or the central pain sensitization. And so we find out that redox signaling control the pain neuroplasticity, the wiring of the pain pathways. And we will see here the effect of ROS on synaptic plasticity are ambivalent. The production of ROS during normal signal is essential for establishment of plastic changes, while excessive ROS production and consequence of ROS accumulation lead to the developmental process that impairs synaptic plasticity and cause cellular injury. And that's what's happened also for patients with Alzheimer, Parkinson's disease, because of the free radicals, they induce the degeneration or cause degeneration in those conditions. Oxidative stress occurs when antioxidant defense cannot balance the production of ROS. The age-dependent decline in synaptic activity and memory and cognitive function is closely related to oxidative stress. ROS overproduction is involved in several neurological and psychiatric conditions or pathologies, including Alzheimer, Parkinson's disease, motor neuron disease, hyperalgesia, allodynia, phantom pain, depression, and schizophrenia. I'll be focusing more on hyperalgesia, allodynia, phantom pain, central neuropathy, and we're going to discuss that. And I'll make it so easy for you guys. If I pinch my hand, what will happen? I'll produce enough of noxious stimulus that will stimulate the neuroceptive neurons, the peripheral one, which will carry the signal of pain into the central neuroceptive neurons, as you see here. And then what will happen? It will cross to the other side, and then it will go to the thalamus, or spinal thalamic tract. And when the pain signals reach the thalamus, that's where you feel the pain. But I start feeling the pain, but I know where the pain comes from. In order to know where the pain comes from, there will be another order of neuron, which is called the thalamocortex. They will carry the signal into the sensory cortex, and that's when I start knowing, oh, the pain is coming from my hand, which I pinch it. All right. So, what would happen if I fracture my arm? I'll produce very strong noxious stimulus that will cause massive pain signals carried by the peripheral neuroceptive into the central neuroceptive neurons. And they will form the synapses at the dorsal horn of the spinal cord, lamina 1 and lamina 2. Okay, so peripheral neuroceptive neurons, as you see there, they are mostly glutaminergic neurons, substance P producing neurons, and they will be producing massive amount of glutamate. And the glutamate, as you see there, they will cause opening of NMDA receptors, which will activate the central neuroceptive neurons, yes, and cause a depolarization, but also calcium influx stimulate the Knox enzyme. Knox enzyme produce or generate a lot of free radicals, and then the free radicals will stimulate the structural and functional synaptic proteins and cause what we call the progressive pain neuroplasticity. What is progressive pain neuroplasticity? What will happen, the synapses will increase in number between the peripheral and the central neuroceptive neuron. The number of the synapses will increase. The communication and conduction between the peripheral and the central neuroceptive will increase. And that will lower the threshold. And if you lower the threshold, you would have something that's called primary hyperalgesia. What is primary hyperalgesia? When you press on the side of the fracture or site of the injury, you will feel tenderness. What else? The central neuroceptive neuron dendrites, as you see here, they are starting outgrowing, projecting, and they will reach to the axons of the peripheral neuroceptive neuron that's coming from the area around the site of the fracture, around the site of the injury. So what will happen? When I press around the site of the injury like this, I will feel tenderness, and that's called what? Secondary hyperalgesia. What else? Well, those dendritic from the central neuroceptive neurons, they will also project and growth and reach out to the tactile neurons in lamina 3. And what will happen if they form synapses? When I start just a little touch of my hand, I will feel pain, and that's called what? Allodynia. Okay, so you see here now, this is hyperalgesia, secondary and primary allodynia. Is it pathology or it is physiology? In other words, is it good or bad? What do you think? Good and bad. Is it good to have allodynia hyperalgesia when I'm having fracture? Yes? Yes. Why? Because it will help to protect me from moving my arm and allow my bone to heal, right? So it's a defensive mechanism. It's good. But when my bone is healed, right, and I have no peripheral lesion, normally all this circuits, which is defensive protective circuits, I don't want to say abnormal now, normally they have to regress back. So regressive neuroplasticity, they have to shrink back into its normal refractory, we can say, setting pain circuits, right? And there will be no pain. And I will not feel any pain after my bone is healed. But in some patients, that doesn't happen. And they will continue firing signals without any external stimulations and that's called what? Phantom pain? So the patient will come to you and say, yeah, my fracture is healed, but I still feel the pain, same. There's no, I feel pain. And most of the doctors think that this patient is faking it and is trying to get narcotics. But the fact is that that's not true. He is have pain, it's real pain, we call it phantom pain, and it's because of this, now it's become abnormal circuits, right? This is pathology. It's called phantom pain, and we can call it also central pain sensitization, or we can call it what? Central neuropathy, right? Okay. Let's finish up the story of the central neuropathy because it's involved more than abnormal circuits. The free radicals that is produced in those synapses as they are continuing active and firing high frequency stimulations, those free radicals, they will irritate the surrounding glia cells. You see those glia cells? I turned them to red there, blue normal then. And then they become what? Gliosis, astrocytosis. Now I'm adding what? Neuroinflammation. And what will happen is that they start releasing or secreting free radicals. And these free radicals will shift the oxidation status into both oxidation, right? So what will happen? This will add and feed into the central pain sensitization and add more central pain sensitization. And it becomes neuropathy with neuroinflammation. Okay, what else? We know we have an analgesic pathway, which is this descending one, that secretes norepinephrine, that secretes glycine, gabapentin, right? Enkephalin, and they form synapses with these neuroceptive neurons. You see there? And their job is to suppress, inhibit, hyperpolarize the central neuroceptive neurons, right? They secrete those neurotransmitters and they cause hyperpolarization, inhibition, analgesic. But those free radicals that's being released from the gliosis and from the astrocytosis, they will cause regressive neuroplasticity in the analgesic pathway. Okay, so what will happen to their number of the synapses? They will decrease, and that will decrease their inhibitory effect. And what will cause that? An increase in the pain sensitization and more central neuropathy. Right, so you have progressive neuroplasticity in the analgesic pathway. You have, regressive, neuroplasticity in the analgesic pathway, and you have progressive neuroplasticity in the neuroceptive pathways. Okay. Still, we have something called amygdala, which is the circuit that stores the memory of pain and the trauma of pain. And that memory circuits, it feeds into the central pain sensitization and activate it. And the central pain sensitization pathways, they feed into the amygdala, the memory, and they activate the circuit and causing high frequency stimulation. So when you do high frequency stimulation, you increase that strengthening of that memory. So that's why the patients, when they think about the trauma or pain, they still feel more pain, right? And when they have the pain, they start thinking about the trauma itself. So there's a vicious circle there. What else? This amygdala, they project into the hypothalamus, and they cause activation of the sympathetic and causing sympathetic overactivities. And when you have sympathetic overactivities, what will happen? You produce a lot of norepinephrine, epinephrine, and norepinephrine and epinephrine stimulate the NOx enzyme, causing more shifting and oxidation, right? And that would add more to the pain central sensitization. So, how we manage central neuropathy? Do we give them morphine pump? Spinal cord stimulator? Before we go there, I think we can do a lot of integrative, regenerative medicine to restore the nitroredox balance, to help to decrease those free radical production. And if we do that, we may be able to cause regressive neuroplasticity in the central pain neuropathy. Okay, so what we're doing now when we treat it, we give them opioid, right? And when we give them opioid, yes, it will numb the central neuropathy because opioid receptors is there in those synapses. And yes, it will cause hyperpolarization, inhibiting the central neuropathy. But what's the problem with opioid? Continuous stimulation of the mu receptors cause activation of NOx enzyme. NOx enzyme goes shifting the oxidative status into more oxidation, more free radicals, which will cause what? Pain sensitization. So you need to give them more narcotics, right? And narcotics goes inhibition, yes, in the beginning. It suppresses the mu receptors, but chronic stimulation of mu receptors leads to more free radical production through the NOx enzymes. And this will cause more progressive neuroplasticity in the central pain pathways, leading to more of central pain sensitization. That's why we have what we call adduction. This is the mechanism of adduction, drug addiction. All right, so we give them what? Gabapentin. Gabapentin, yes, we have a receptor there, will inhibit, will suppress, but the problem with gabapentin is toxic to the mitochondria. And when you toxicate the mitochondria will start leaking free radicals. and shift the whole oxidation back to oxidation, shift the oxidative status to oxidation, which will increase the pain sensitization, so you need to give more gabapentin. Alright, so what will you think? What other things we have? Steroid, let's give them steroid. Well, steroid is good because you will decrease, if you have pinching nerve, inflammation of the peripheral side, it will help. It will help also to inhibit the NOx enzyme, steroid. Don't take me wrong, steroid is good. Steroids suppress the whole free radical generation. In the brain, in the periphery, it suppressed everything. It also suppressed the NOS enzyme, which is the nitric oxide synthase enzyme. And so what would happen if you give them chronic use of steroid? Atrophy in the muscles, in the nerves, secondary hypertension, because they suppress the NOS enzyme, there's no nitric oxide production, diabetes, secondary diabetes. So we have lots of side effects of doing steroid. And yes, when you give them steroid and you suppress the free radical production, you increase the tryptophan and you increase the serotonin. And that's why patients taking steroid, they feel euphoria. And they don't want to, if you ask them to cut it down, they say, no, I want my steroids, because it gives them some sort of euphoria there. Okay, so what are the things you suggest to treat? But instead of masking the problem, why we don't go back and understand that pathophysiology of central neuropathy is because of overproduction of free radicals. It's an oxidative stress, and if we redefine central neuropathy as oxidative stress and manage it as such by screening all the free radical generators and restore the nitric oxide balance, I think we can manage it. And how we can do that? Of course, we can do that by screening the toxins and detoxifying the patient. That would be a good start, right? And I think Dr. Steve Willer is here. He's very good in this. Well, while you're sending the urine for narcotic compliance, why we don't ask for testing the oxidative stress markers in the urine? Because if it's high, then instead of giving them more narcotic, I can go ahead and manage oxidative stress, which is the cause of that drug addiction. So, screening the urine for compliance and also for measuring the oxidative stress markers will be a great idea. Leaky gut syndrome, have you heard about it? Could be leaking of free radicals, could be free radical generators. All the toxins in the gut, they go into the brain and they generate free radicals. If we can screen that and manage it with pre and probiotic, that would be great. If the patient has any problem with malabsorptions, I think it would be good to fix it. Make sure all your patient's sex hormone is being balanced. It helps to restore the nitric oxide balance. They feel better, right, generally. Thyroid hormone, vitamin B12. I recommend vitamin B12 injections to all the patients with central neuropathy. It helps because it is free radical scavenging, a very powerful one. To the point they are giving it to patients with motor neuron disease as a free radical scavenger. Now, a lot of doctors will say, oh, I'm going to go with only mainstream drugs. That's only approved by FDA. Well, the fact is that the mainstream drugs that we have in motor neuron disease, they are free radical scavenging. Radicava is a drug that's been FDA approved, given to patients with motor neuron disease. It's a free radical scavenger. Radicava. Right? One other thing we give for motor neuron disease. Ribosol, it's a glutamate receptor blocker. We know that the reason they're giving it, because when you block the glutamate receptors, you block the calcium influx, you block the NOx enzyme, you block the generation of free radicals. So the two drugs that we're giving for motor neuron disease, they are redox buffering drugs. Beta-12, methylcobalamin, it works like ribosol. It is also glutamate receptor blocker. In addition, it is a free radical scavenger. In addition, if you have problem with patients that metabolism vitamin B12 or folic acid, they have the tetrahydrofolate reductase deficiency, they will have homocysteine, right? High and homocysteine can cause what free radical, it's a free radical generator, and I think injecting vitamin B12 for our patient with central neuropathy, they will feel better, and I think it will help to manage the pain central sensitization. Vitamin D2, also very important. The other thing, as you see, and I think Dr. Albert Ray, he's profession in that, is the cognitive therapy. Why cognitive therapy? Because we know that amygdala is where we store the trauma, the memory of the trauma, right? And if we do the cognitive therapy and meditation and sport activities, and we use the prefrontal cortex, right? We activate that, or make the patient use it, to take the conscious out from the memory of the pain, from amygdala, to other activities. What will happen? This will weaken the circuit of the memory of the pain. And if you do that, you decrease that activation that is coming from the memory of the trauma, and you will decrease the pain central sensitization. So, exercise, biofeedback therapies, cognitive therapy, meditation, all of this will help to distract and take the conscious away. And if we do that, then there is no more, or the memory and the circuits of the neuron that stores the information of the trauma will become weak and weak because there's not much of frequency stimulation there. And what will happen, you will have what we call the regressive neuroplasticity, and that's what we need. We need the patient to forget about the pain. And I think Dr. Albert Ray is the leader in this field. Before personalized nutrition, genetics is very important. As we mentioned, tetrahydrofolate reductase, it's methylene abnormal, methylene metabolism. All of this can be source of free radical generators. It's good to fix that. If you're giving a drug and that drug is not abnormally metabolized in that person, it's good to do pharmacogenetics so we can give the right drug for that patient, because abnormal metabolism can be source of free radical generation. Recommending a package of supplement, yes, multivitamin, minerals, thiols, polyphenol, nitric oxide, antioxidant, epigenetic. All of this can help to restore the nitric oxide balance and help to induce regressive neuroplasticity in the central pathways. A healthy lifestyle, fasting, exercising, meditation, implementing regenerative medicine, integrative medicine, energy medicine. Photomedicine will be another option, because photomedicine does buffer the redox. You do it intracranial or transnasal, that would be a good option. And the last thing is that when we do any kind of therapy, it's good to have a diagnostic test that can objectively measure the effectiveness of the treatment in order to say this is evidence-based medicine. Just saying, oh, I feel good, it's not enough. So we know that if you have pain, that means you have sympathetic overactivities, right? And there's a test there, it's called autonomic nervous system testing, that can test the sympathetic activities, okay? So this indirectly can be an objective diagnosis for pain by using ANS. That will help to diagnose pain. It's billed by insurance, it's FDA approved, the ANS testing, and one of the code is pain. And I think we saw the relationship between pain and sympathetic overactivity. So when you give all these medications, all these treatments, sympathetic goes down, that means you're on the right track. The other thing that you can use endothelial function test. Patient with high free radicals, they damage their endothelium, they will have abnormal endothelial function test. So if you improve the endothelial function test, that means your treatment is working. That can give you some objective clue or feedback that you are treating the patient. If you have neuropathy, diabetic neuropathy, and you want to monitor the effectiveness of your treatment using topical cream that contain nitric oxide, polyphenols, and thiols, I call it nitrocompounding. Yeah, you can use pseudomotor testing, right? Okay, so I have a patient. I think the most difficult to treat pain condition is complex regional pain syndrome, or RSD. I think it is second to the cancer pain. Sometimes it's even worse than cancer pain because you cannot even touch those patients, and they end up with amputation. So this is a 42-year-old man presented to my office with history of left arm pain and swelling for a duration of 5 years. The patient twisted his left arm at work while drilling a hole in the ground. He was diagnosed with ulnar nerve entrapment and underwent a complicated ulnar nerve dislocation surgery, which progressed into left upper limb RSD, and he had received series of unsuccessful left cervical ganglion steroid injections, block, sympathetic block. The patient suffered 5 years of constant and severe left upper limb swelling, deep aching pain, allodynia, hypergeusia, discoloration of his arm, and he was on the highest dose of narcotic without any relief. He lost his job, disabled, and sustained a harsh economic and social life, to the point that he was separated from his wife and his family. After 6 months of serious blue, infrared, and red photobiomodulation, I was directing it into sympathetic ganglion, so instead of injecting with steroid, I put light in his neck. And then in the beginning, you cannot put the light, in other words, you cannot put the probe of the laser system on the skin because it's very sensitive. So you do showering with the light. And with, I think for 6 months, you need to be patient with those patients. 6 months, twice a week, around half an hour of phototherapy. So after 6 months of serious blue, infrared, and photobiomodulation therapies on his left arm and left cervical sympathetic ganglions, along with application of topical nitrocompounding that's very rich with polyphenols and thiols and vitamin B12, the patient recovered from his pain, weaned from narcotic, returned back to his work, and he was able to perform his normal daily activity. This was a miracle for me. This is when the time I contact Dr. Hamblin from Harvard Medical School, and I published 2 articles with him. And in the beginning, like you, exactly. I mean, I was thinking, light therapy is just a snake oil, but after this, after successfully treating RSD, I started involving more into laser, we call this photoregenerative medicine or photomedicine, and then I started involving in also cancer photodynamic therapy, and it's become my hobby of interest. Now this is in Germany. This is me treating my dad in Germany with Dr. Michael Weber. What's the unique about this? Yes, we are injecting methylene blue. We're also injecting ICG because they are sensitive to infrared. And we are injecting low-dose Doxil, very low-dose chemotherapy, photoactivating the Doxil with blue light. So this is called triple nano chemo photodynamic therapy, right? And what's the good thing about it is that, yes, we did this with under anesthesia when we inject the hyperpharyngeal with this photosensitizers. And then of course, we end up doing light with a catheter inside and activated. But we did it under anesthesia because of the gag reflex. But then I insist to Dr. Weber, let's do it without general anesthesia and do the injection. It's risk because if he gag and needles out, he may injure his throat, right? But we took the risk because it's not feasible to put the patient on anesthesia every day, and I want to give him that injection every day. So we did it, and this is being done without any general anesthesia. We're able to put that gastroscope and get that needle out and inject his throat against the gag reflex with success, and we're able to inject the tumor, as you see it there, with methylene blue, Doxil, and ICG, which we call it the triple nano chemo photodynamic therapy. This is a target cancer therapy. And methylene blue sticks into the cancer cells. He has, in the beginning, has difficulty of swallowing, even he has a problem with food. Now he can eat and drink. Almost 70% of his tumor shrinked. He is very excited, very happy. It was an operable condition or cancer condition because it was located in a very sensitive area for them. It's just hard to remove it. and they recommend strong high-dose chemotherapy and radiotherapy. We did low-dose chemotherapy with photosensitizers, and we have great success. There's only one article who did the similar thing with methylene blue. It was in Germany. A surgeon has done it. I will share it with you, an article, if you send me an email. That's the only one on human. It was done on animal, on lab, done on lung cancer. It was done on squamous cell carcinoma of the skin. I remember breast cancer, but we don't have much of publication there, so we need to work with. And this is when we put the catheter of the red light in the throat, throw the nasal, we call it the nasal gastric tube. We put the catheter in his throat nasal pathway. Now, people, and a lot of you will think how light can help pain. If you redefine the pain as oxidative stress, and you're managing pain by buffering the redox, then this is how the light works. It works by increasing the nitric oxide bioavailability, which nitric oxide can be analgesic, and also it buffers the redox. When you shine the light into a healthy ischemic inflammatory lesion, but when you shine the light into a healthy tissue, it's the opposite. The electron that's excited from the mitochondria, they will be picked up by the oxygen and they become what? Free radicals. So you're increasing the free radical. Now, people will think, okay, you're increasing the free radical, so how are you treating inflammation? Because when we are shining the light, we're shining the light in the healthy tissue that's around the lesion. Same concept of prototherapy when you are putting dextrose as an irritant to increase the free radical. And when you increase the free radical, what will happen? It will stress the healthy tissue to produce growth factor, cytokines, and antioxidant, anti-inflammatory cytokines. And what we call this process, it's called mitohormesis. Okay? Mitohormesis. Okay, so if you shine the light in a healthy tissue, you get an increase in the free radical, a spark of increase in free radical, which will activate the antioxidant genes, the anti-inflammatory cytokines, the growth factors. And that's the same concept of prototherapy, electrotherapy, even your spinal cord stimulator that you're doing. In addition, it helps to interrupt the signal of pain through depolarization of the neuropathic pain, or maybe possible activation of analgesic pathway, or stimulation of the tactile neurons, and then tactile neurons will inhibit the pain. So, in addition to that, I think it's better if we also look to other modality and buffer the redox, because if we do that, we can induce the regressive neuroplasticity and central pain sensitization. Now, when you shine the light in the inflamed hypoxic lesion, what will happen? Those excited electrons will be reducing the NAD and become NASH, and that will lead to shifting the oxidation status into what? Into reduction. Doing that, it gives you direct anti-inflammatory effect to the lesion. So light therapy, it is, you can say antioxidant, anti-inflammatory, spinal cord stimulator, in addition to interruption of the pain. It also, those electrons that's being released can also neutralize the free radicals and buffer the redox and involved in buffer. So spinal cord stimulator, in addition to interrupting signal of pain through hyperpolarization, depolarization of some pathways of analgesic and neuroceptic pathway, it also helps in buffering the redox, and possibly that is part of its effect in regressive neuroplasticity. Blue light, when you shine into the hemoglobin, they release the nitric oxide, and then nitric oxide reacts with the free radicals, they become peroxynitrate, and then the hemoglobin will take the peroxynitrate and recycle it back to nitric oxide. The ultimate effect is shifting the redox into reduction. So it has an anti-inflammatory effect. Now, this will be the last slide, all right? And this is called photoregenerative medicine. And you click on Google and you'll see there's something called photoregenerative medicine, which is activation of stem cells. As we know, that dumping stem cells in the joint without any activation, without perfecting the microenvironment, is like dumping a seed in a desert expecting a garden of flowers, okay? So we need to perfect the environment. One way we can perfect the environment is by phototherapy. And I think Dr. Pureta, which I'm the one who introduced to him the phototherapy with stem cells, and he started having great results with it after I published it with Dr. Michael Hamblin. So the question is that a lot of doctors would think, so what I would do if I have a patient with osteoarthritis, I would do bone marrow, stem cell, fat, or PRP. What do you think? If you have osteoarthritis, half of the cartilage is being damaged. Regardless of the money thing, let's go with honest, efficacy way, economic way for the patient. They give you the choice, what you would choose. PRP or bone marrow stem cells? Huh? Bone marrow. Anybody will go against bone marrow? Alright. Now the question was said, bone marrow, are you building cartilage when you inject it? What you will tell the patient? Are you building the cartilage when half of those cartilage is being removed or being, wiped out because of the aging? Do you have evidence of? So you can tell the patient that if I give you bone marrow, stem cells, or fat stem cells, your 50% of the cartilage that's being messed up, it will return back. Can you say that to the patient? There is no any evidence that we have significant regenerative effect to the cartilage. It's only slowing the progression of degeneration of the cartilage. But really, we don't have much. And just slowing the degeneration, it's good, right? Yes. But can we do it with PRP? Yes. And we can do it as effective as bone marrow if we combine the PRP with light, and also we do some cream that contain the polyphenols and thiols to perfect the microenvironment. I think it's enough. Now, the other thing that we are missing, because we are focusing on what is being damaged is cartilage, so we're fixing the cartilage. But the reality, there's more than we are fixing the cartilage. When we're injecting stem cells and PRP and fat, we are improving the synovial production, the lubrication. That is even more important than slowing the degradation of cartilage, which will slow the degradation of cartilage if you are able to improve the synovial fluid production, the lubrication. And yes, if you argue with me and say, well, we can replace the bad synovial cells with the good ones when we inject the stem cells. Yes, I will say that's possible. But cartilage, but synovial cells can be replaced, you can have some regenerative effect. Yes, but can we do it with PRP? More economically, it will cost the patient $500 versus $5,000. I will go with a photo-activated PRP, but I will not dump the. Can you give me 5 minutes? No? Okay. So I think the time is over. But I think I have conferences coming up, so you can come and attend it when we finish this. Any questions? Questions?